Thank you very much. I'm really sorry that I'm not there, but you know we're running another congress. There are 2 more congresses right now in Athens, so we have to be everywhere. Anyway, I would like to thank the organizing committee and especially Kostas for the kind invitation to participate. And let's go directly to the speech because I think the time is running. So the title was given about the TAVI durability and long-term outcomes. It's always a question regarding the long-term outcomes of viable bioprosthetic valves. There was an argument regarding the surgical long-term outcomes that they always are better than the unknown long-term outcome of the TAVI valves. However, now we have several data. The first thing that I would like to point out is that, as we know, with aortic valve disease getting older, and since we are in Greece, you can see that the incidence of aortic valve disease is growing and the prevalence. So we are getting more and more patients with severe aortic valve disease. What we knew regarding the long-term physical history of aortic valve disease is known that if it's symptomatic, then the long-term outcome of these patients is not favorable. In fact, more than 50% of the patients with symptoms are not living more than 5 years. So long-term outcome, if you don't intervene, then there is a problem. We know the classic slides from Carambello and previously in aortic valve stenosis. What we know also is that there is a disease progression, especially in calcific aortic valve stenosis, and that's why you can see the growth, the increase of the velocity transvalvulary. So there are several factors affecting the growth of the aortic valve stenosis, and we've done several experimental studies. We published last year in the JACC Science a proposal regarding the role of spongiosa in the middle layer of aortic valve disease and how this may play a role in progressing aortic valve disease. And we've shown that there are several pathways. Hypoxia may play a significant role, and the VICs that they are around this area of spongiosa may also promote aortic valve disease, and therefore it might be an increase of the velocity of aortic valve disease progression. So there are several factors. However, let's focus only on TAVI. We know the history of TAVI. We know the last slides, the last valves that we have from 2002. The growth of TAVI the last years and the expected growth that we're going to see. The annual outcome that there is more than the surgical aortic valve disease replacement, TAVI is getting more and more increased. The same means in Greece. We have now 22 centers of TAVI in Greece, and 23 actually. We have last 2 months, and you can see that the mortality how was decreased the last 10 years in all these centers. We know the guidelines. I don't want to lose you now the time, but you know the guidelines that for sure TAVI is getting a special population that is needed to be done. More than 80 years and 65 to 80 ACC and AHA promotes both treatments. However, we can see that TAVI is getting more and more population in this area. And why is that? Because we know that several factors affecting TAVI are favorable. All these factors are favorable for TAVI compared to surgical outcome. I want to pass this slide because the time is running. So, what we know about the long-term outcome of the valves? We have the self-expanding valves and the balloon expandable valves. However, only for 2 valves we have long-term data, for the Medtronics, the Evolut, and the Sapien from Edwards. There are, of course, several trials ongoing. However, if we're going to see the low-risk patients, because the high-risk patients, we know that we don't have any significant and important data because these patients, unfortunately, don't live too much due to extra cardiac reasons for mortality. So we have two large studies starting in 2019. This was partnered 3 trial comparing with the yellow the surgery and the blue the TAV. And you can see that the primary endpoint was similar with a p-value of 0.07. The primary endpoint, I remind you, was death, stroke, and rehospitalization among the two groups. Actually, the all-cause death with a p-value of 0.35 was favorable. It was exactly the same, 10 and 8.2% at 5 years post the implantation. And you can see that the quality of life and the durability at 5 years was the same. And also the stroke was with a p-value of 0.6, exactly the same between the two methods. And rehospitalization was almost unfavorable for TAVI with a 0.09 p-value. So regarding the non-inferiority, we can say that in both trials was, in both approaches was the same. And I would like to point out that it's very important because if you see in low-risk patients in the United States of America, you can see that more than 50% are getting TAV compared to in 2021, 52% of the patients are getting SAV and 42% are getting TAV in patients less than 65. So we are getting in a very low risk population and you're getting this, and you can appreciate that it's getting increased and decreased in patients with the surgical approach. So we need long-term data. The Evolute low-risk trial was one of these trials that they provide us almost 4 to 5 years data, and you can see that it was, for the first time, you can see that it was in favorable of the Evolute TAV compared to the surgery. At 4 years, the primary endpoint, which was mortality and disabling stroke, 10% compared to 14% in this population. And you can see the stroke and the mortality, how was different. Mortality was 0.07, the p-value. And you can see if you add rehospitalization, then the p-value is getting 0.04 compared to the surgical treatment. And this might be explained by the last data that we saw 1 month ago in the American College of Cardiology, in the study that was performed regarding comparing the two, the SAV and the TAVI, and you can see 5.4 in the German study compared to 10% in the SAVI of SAV in patients with in low-risk patients, death and from any cause or stroke, which was significantly increased, and also the SMART trial comparing the balloon expandable with the self-expanding valve in the after randomization, and you can see that it was the first study demonstrating that at 1 year the trial met both primary endpoints. There was no significant difference between the groups in death, stroke, or rehospitalization. However, the self-expanding valve was for the first time found to be superior in terms of valve function, defined as in terms of structural and non-structural valve deterioration. So for the first time, seems that a self-expanding valve may have better results and maybe explain the better results from the Evolute trial. Now, regarding the long term, what we should focus on? We should focus on several factors. One factor is the endocarditis. The other is the leaflet thrombosis, the structural valve deterioration, local inflammation, mechanical stress, immune-mediated calcification, and the non-structural valve deterioration resulting from mainly from the procedure, incorrect valve position, or PPM or PVL. These are the factors affecting. We published in 2021 this interesting study in the American Journal of Cardiology. The first author is Stavrogiannis Konstantinos, who is now in HYGEIA. And you can see that the cardiovascular mortality in very high-risk patients at 8 years was 8%. However, the major problem was non-cardiovascular mortality at 8 years. And if you see the after the long-term follow-up of this high-risk population, you may evaluate that. I'm sorry, I passed it. That the valve size was a very significant factor affecting the long-term mortality. The smaller valve size, the worst outcome of the patients. In the national trial, also, we have 10 years comparing SARV and TAV in low-risk patients, and you can see that there was no difference between the two groups, 64 and 62.7, the mortality rate. So this is in favor of the TAVI, that you can have a minimal invasive strategy. And also, if you add stroke and myocardial infarction, you can see the same percentage. Structural valve deterioration between TAVI and SARV, you can see that I'm sorry, I don't know why it happened. Okay. You can see, I don't know what happened. I'm sorry for that. Okay, I'm going again to show the slide. Moderate structural valve deterioration, 19% in TAV, 36% in SAV, and the severe structural valve deterioration, 3 versus 11 in the SAV group, and the modified moderate structural valve deterioration was also had also the same results. Bioprosthetic valve failure, valve-related death, no difference. Severe structural valve deterioration, 3 versus 11 in the surgical group. Aortic valve reintervention, no difference between the two groups. This is a patient that I had the permission. George was there when we presented it last year. You can see him in the photo. This patient was performed in 2008, and you can see his echo. This is 16 years after the TAVI. You can see perfect bioprosthetic valve, and this is our target to have such groups. So this is the smaller valve, and for the long-term outcomes, I've already showed you this data. And we also proceed in the whole Greece, the long-term follow-up. We proceeded. A sub-analysis was presented in the European Society of Cardiology Congress, and we saw that post-TAVI, the pulmonary arterial pressure was a predictor for 8 years mortality. This was significant. We have also 10 years follow-up right now with 27% cardiovascular disease-related deaths and 10% strokes and 20% heart failure hospitalizations. We have the long-term of DIRECT trial that we've showed several times here in Greece, and there are several ongoing trials. I don't want to lose now our time. I just want to focus on this, that we're trying to have a multi-center trial with the beta blockers, if the beta blockers play a role or not, also in the low-flow, low-grade. So in conclusion, I would like to end that and focus that on the long-term results, that they are reassuring that TAVI, regarding clinical outcomes and valve durability, are at least similar with surgical follow-up. Further data, of course, is needed regarding the low-risk groups. Of course, it's a hard team approach, and we need more and more data regarding the long-term outcomes. Thank you very much for your attention.
Great. Many thanks, Costa. This is a great presentation. May perhaps I want to introduce that we have Dr. Damaskos on the connected. If you have any, welcome. We can see you. If you have any comments, go right ahead. And I will also like to invite Professor Michael Reardon to join us in the panel up here, if you would like, and offer some comments afterwards.
Thank you, Professor Dagas. Apologies, I've not been able to attend as I'm currently abroad. Professor Toutouzas made an excellent speech. TAVI durability is really, really very important. It will become even more important as the years progress. Yeah, and perhaps as they did an excellent work on identifying pathophysiology of the mechanisms that destroy the native valve, perhaps we have to look at similar mechanisms that might destroy the TAVI valve or any kind of biological valve, even the surgical ones. Currently, we have from the STS ACC registry about a 7% rate of valve-in-valve that we are performing, and this is something that will certainly increase in the future. So we have to identify common terminology, common benchmarks for this kind of operations, and we all have to work towards trying to better place our valves so they will last longer, and even valve valves will last longer because we keep treating younger and younger patients.
That's great. Well, let's ask the Professor Reardon, University of Texas, a world expert of that, and then Dr. Kilic, to tell us how do you, the durability is related with what we call lifetime management of aortic stenosis in some ways. But whenever I opened up this discussion with any patient, or they don't fully understand what I'm talking about. They have difficulty understanding what is a projected well-being in a horizon of 10 to 20 years, and probably they tend to minimize what I'm trying to get across to them. So how do we figure that out, except for outside, of course, innovation in TAVI and all that? Dr. Reardon and then Dr. Kilic.
Well, George, I think that the surgeons, we deal with this all the time. Patients walk into my office and say, well, the cardiologist says a tissue valve will last 10 years. And I tell them that's a meaningless statement. I need to know how old you are to begin with, what's your physiologic state. It's different for every patient. Every heart valve is going to fail at a different rate, both surgical valves and TAVR valves. It's not a class effect. It's related to valve design and tissue science. I do plan to present the low-risk Evolute trial at ACC next year, and we'll see if the curves continue to diverge. And we did present the 5-year durability data on the Evolute valve from the high risk and intermediate risk, and found that it was actually higher in surgery than it was in TAVR, and it was related to a doubling of your mortality if you had moderate or greater structural valve deterioration, a doubling of your cardiovascular mortality, and doubling your rate of rehospitalization, which probably explains why we're seeing the curves diverge between surgery and TAVR, since TAVR with Evolute has a Doppler velocity index of 0.61 and surgery is 0.5. The bigger opening you start with, the longer it takes that valve to fail. And I think that's why we're seeing this.
Bigger is better then. Dr. Kilic and then Dr. Tsolakis, maybe.
Since there's a tendency now to do TAVI in young patients, durability is very, very important point to be considered. So, but most of the durability data is coming from the old generation valves. But also newer technologies are coming and novel valves are coming. So the exact mechanism also underlying structural heart valve deterioration must be also much more clearly determined. Also, I mean, what is the, for example, definition of the real structural degeneration? Only gradients or on other points? So all these points must be considered also according to the new criteria also of the Vascular Academic Research Consortium. So the old generation valves, most of the durability that are coming, these data also must be re-evaluated, my opinion. And we should also think about younger patients. When a young patient comes, durability is important. If the patient had also a surgery chance, we can also think about surgery.
I would like to say something different than you. I see that the patients that have a tissue valve, either in SAVR or TAVR, the main problem is that the patient in a big age, in the higher age, can continue to live without doing anything more but living by food, small exercise, and so the durability is very good for them. The main problem remains for the patients which are in lower danger and in a lower age. So, first of all is the size. The second is the exercise. if you have a young patient with big exercise, with many exercise, so you cannot have durability. And the second thing is the size of the valve you can put. Many surgeons prefer to put size bigger, but the best we can expect from the valves is if we have a big annulus, we can have very good durability. Small annulus means small durability.
Yeah, no question about that. And again, coming across to the patient's priorities, on the older patients, better durability. The younger patients, you know, the not so good durability, but again, you see there's a lot of push of younger patients to not take anticoagulation, go against a mechanical valve. A lot of them now, the newer push, I don't know, perhaps a New York phenomenon, they don't want to take time off. So they really have too many things going on. They say, oh, you know what, I don't want to take the recovery, this, that. It's just very difficult to get through to them. We are, of course, but it's just like every age group has different priorities and different concerns. Let's look into optimizing TAVI outcomes, though, is our next subject, because durability is only good if you have a very, very, very good result up front. You have a bad result up front, there is no durability. So let's hear my partner and a fellow of the Society of Cardiovascular Angiography and Interventions, the first heart surgeon to join the FSCI program, Dr. Gilbert Tang, who is going to talk to us via the video due to the fact that right now in New York is like 3 a.m.